Good day, everyone. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination here at the Task Force for Global Health in the United States. It's my pleasure to, first of all, wish you all a very healthy and happy, productive new year, and to introduce you to our first episode of our ongoing webinar series, Hep Test for 2022, where we'll be looking at ways to optimize hepatitis C testing and linkages to care, exploring different strategies for laboratory-based reflex testing. Next slide, please. You know, this is, as we all hopefully know on this call and on this webinar, testing is key for preventing hepatitis C, as well as linking those persons to care and treatment. And as illustrated by this slide from WHO data that was released in May of last year, we still have a ways to go of getting people tested, diagnosed, aware of their status, and receiving the care and treatment they need. As you can see here, only about 1 in 5 people living with hepatitis C have been diagnosed. And so we have some work to do, and that's where it comes down to what are the strategies that can help scale up testing. And here at the Coalition, we're very interested to see, beyond policy development, what are the real strategies for implementing that policy so that policy becomes action that improves patient care and then by extension helps us accelerate progress toward hepatitis elimination goals. Next slide, please. And what we're talking about today is laboratory-based reflex testing, which we define a specimen is collected at the point of clinical care, either a venous sample, or it could be a finger stick for a dried blood spot, as you'll be hearing about in our program today. And then that specimen is forwarded to the laboratory where antibody testing is performed. And then if that antibody test is found to be positive, then that specimen is automatically forwarded for HCV or core antigen testing to confirm the presence of HCV infection without the need for an additional specimen to be collected or additional input from the clinician, therefore automating and simplifying the diagnostic process. We're going to be exploring how that has actually been implemented in a variety of different settings, looking at it from both the laboratory point of view and from the clinician point of view. Next slide, please. So we're going to be looking at issues of implementation in the laboratory, as is laid out in this slide, some of the cost and economic considerations, also changes in clinical care, feedback of information to the clinician, and how that impacts HCV testing and confirmation of HCV infection. Next slide, please. So as we go through our program, just want to again remind you to place your comments and questions in the chat or the Q&A feature. We'll be monitoring both so that we can raise those questions and comments to the presenters and through our discussion. That will be kicked off with Philippa Easterbrook, who will be joining us from WHO. So at this point, I would turn to our 3 presentations. We'll be hearing about reflex testing in British Columbia from Agatha Jasmine, reflex testing in clinics for persons experiencing homelessness by Andrew Seaman from Portland, Oregon, and then reflex testing in England by Ruth Simmons and William Burdine. So with this, the next slide, I'll turn it over to Agatha to present their strategies for reflex testing in British Columbia. Welcome, Agatha.
Thank you very much, and thanks for having me. Let me just screen share here and go to presenter view. How does that look? Can you hear me and see everything okay?
Looks great. Thank you.
Thank you. Okay, so yeah, I'm a clinical microbiologist and lead viral diagnostic lab at a public health lab in British Columbia, Canada. So we service the whole province and support the acute care settings. So I want to give you a little bit of data on Canada as a background first. And let me just be mindful of the time there, okay? And so, you know, in Canada, we do realize that there are many cases of HCV that go undiagnosed. So it's estimated that about 250,000 people in Canada are living with HCV, which is a lot for us. We don't have a large population. And about 110,000 of those are unaware or undiagnosed. And that's 44%, so a large group. And one of our challenges in Canada is really geographic distribution, as well as we're, you know, a vast country with lots of remote communities, as well as having priority populations that are lost to follow-up, or that don't necessarily come into clinic in the first place. So it really is our goal to identify those people who are undiagnosed, as we know that that will help get them into care and treatment. And there was a nice blueprint about all the issues regarding, you know, HCV diagnosis and treatment in Canada, printed in 2019, with some details on the strategies that we are aiming to employ. So like was already introduced, in Canada, really up to 2020, and only recently have some labs started HCV reflex testing. It's really been at this two-step diagnostic workflow, where, you know, serum is collected and tested for HCV antibodies. And then if it's positive, it could be a current or a previous infection. And then a plasma has to be collected and then submitted through an additional visit to determine if it's an active infection through detection of RNA. And so about 25 to 35% of people in Canada who test antibody positive actually never have a follow-up RNA test. And it can be up to 73% in those priority populations, like remote populations, indigenous populations, people who use drugs, who are lost to follow-up or have trouble reaching these clinics for blood collection. So again, I'm in British Columbia, Canada, at the Public Health Lab. So to give you a little bit of background, again, you can see sort of the size of British Columbia here. So geography, where, you know, below you've got Washington, Oregon, and most of California. It's large provinces in Canada, not a lot of people, only about 5 million. So a large geographic distribution and some remote communities there. And so here, though HCV testing is mostly centralized, there are a couple of labs that perform serology screen, but for the most part at the BC CDC Public Health Lab, we perform the serological screening test. And then we are the lab that performs confirmatory RNA testing for the province. We do employ two different serological EIA tests for the anti-HCV antibody detection, Seaman, Centaur, and Abbott Architect. And this was implemented a few years back, really to confirm true positive results, or if you think of it the other way, to identify false positives, as we do see some weak signals on our Centaur screen that are non-reactive on the Abbott, which gives us, you know, some insight that it may not be a true positive. So that's a little background. And then right now for our confirmatory RNA testing, we use the Abbott M2000. And really we have been for a long time asking for EDTA plasma. And if you recall, it's really because EDTA plasma is thought to be the optimal sample type for RNA stability. And that EDTA really helps prevent enzymes like nucleases to degrade nucleic acids. So that's the thought there. And some data from 2018, before we implemented HCV reflex RNA testing on serum, within BC, we see that 17% of antibody positive persons did not get tested for HCV RNA. And this is through a testers cohort where we actually, Dr. Krajden and Janjua implemented this cohort of persons that are tested. So anyone in BC who's tested for their antibodies, we sort of capture their follow-up data, whether they have RNA testing, whether they're genotyped, treated, and cured in this cascade of care. And it's really nice data collection. So 17% is not as high as what I previously presented in Canada, which was, you know, closer to 25 or 35% of persons who are anti-HCV positive never getting an RNA test. But this is a testament to, in BC, the really great harm reduction programs that exist, but still 17% of people not getting an RNA test is something that we want to help close the gap on. So we proposed, and I've given some timelines here just to show you, how some of the challenges, but it was back in 2017 that we said, okay, we're ready, let's do this, and propose the one-step HCV antibody and RNA testing protocol, where we were going to perform reflex HCV RNA testing on serum for first-time positives or those who never received an RNA test because they never had an EDTA plasma tube submitted. And there's sort of been three steps that we've followed. First, we had to really verify that serum PCR would work on our instrumentation. Then there were implementation challenges. And now we're in the stage where we're really looking at the performance metrics and looking at how impactful implementing the serum reflex test has been. So I want to highlight, give you the story of what we went through. So initially back in 2017, I believe, we were having conversations with the manufacturer, Abbott. We have a great relationship with our manufacturers, and we said, we'd like to do the HCV RNA testing on serum. Can you tell us how well serum performs on your instrument? And they were, pretty confident that serum would perform well based on this package insert, which quite nicely shows, on the left-hand side here, data for plasma at different concentrations. HCV RNA spiked into negative plasma samples, and HCV RNA spiked into negative serum samples on the right. That with different concentrations of the spike, you still maintain a nice linear range on the assay with comparable values for plasma and serum. So serum was the HCV RNA that was spiked into serum was well detected. However, the issue that we always think about in serum for RNA is, again, stability. So if those nucleases are able to chew up that RNA, then really it's an issue of RNA over time in serum. And using spiked samples and measuring RNA concentrations right away may not be the best way to verify how well HCV can be detected in serum. So given that this was in the package insert, we thought we would do a little bit more work. So it was really important for us to brainstorm what our questions were around how well we can detect this virus. So what we did is in BC, sometimes maybe true elsewhere, we get too many tubes collected on patients. But for this study, that was helpful because we used serum and plasma from 27 patients where on the same day, there was one EDTA plasma tube collected and 2 serum samples collected. And what we did was the one plasma and one serum we tested in parallel upon receipt. And then the second serum sample we held for 10 days post-collection at 4 degrees to sort of mimic what may happen in transport and to test RNA stability over time. So even that first plasma and serum would have been transported to us from an acute care setting and may have taken a couple of days. And then that second sample really sat around for much longer. And this is just the Abbott instrumentation. And what we found is there was really very little variability from that EDTA and serum sample tube tested at the same time upon receipt, and that second SST2 here that was held for 10 days further. I've just highlighted one sample with some variability to showcase, the possible variability. But as you can see here on a log scale for HCV RNA, it was really a variable between the EDTA and serum and the serum samples, where the EDTA actually had less HCV RNA. So not an issue necessarily with RNA stability, just maybe not homogeneous samples reflecting HCV RNA concentration. But for the most part, there was really not, if you looked at the delta log IU per ml of the HCV RNA concentration, there was very little difference between the EDTA and serum samples, whether they were tested at the same time or the serum sample was sent. So 0.1 or 0.3 of a log. So that was really nice data. And then we were quite comfortable to move forward with serum testing based on this, not an extensive validation, but it gave us some confidence. So because it wasn't an extensive validation of stability at, say, low concentrations of RNA in serum, we were still erring on the side of caution and wanted to implement reflex testing only for samples that we thought were reflected true anti-HCV positives. And it was a sort of conservative way to go forward. So we know previously from CDC guidelines back in 2003, and also from our own work, that with our screen on the Centaur, samples with an anti-HCV detected at a signal cutoff of greater than or equal to 11, which is at the top end, are likely to be HCV positives. So those really low signals on the EIA, as well as the weak signals, are likely to be RNA negative. There may be some RNA positives in the weak signals reflecting, maybe waning antibody, low levels of antibody. But really what that tells us is that some of these signals are likely false positives, because we do expect, about 3/4 of the population to have active infections if they have true anti-HCV, given that about 25% may clear spontaneously or be treated. So, and nowadays maybe more treated, but this is sort of more historical data a few years ago. And it really, so again, on the upper end of the signals, that's where we had that 75% of RNA positives. So this is, we were really brainstorming the details of implementation and becoming quite complex. And that's why we decided to really use serum only if the EIAs had high signals greater than 11. So the proposed protocol already had a little bit of complexity. So we said that we would do, for HCV antibody positives, they had to be reactive on 2 platforms, and they had to have strong signal on the Centaur of greater than 11. And it had to be a first-time positive or no prior HCV RNA testing. So a lot of lookup of history, as you can imagine. And then if there was an EDTA plasma that was available at the time, we would actually use that sample, again, to be on the sort of conservative cautious side, for the HCV RNA testing. So now you have a lookup for sample types that exist on this patient. And if there wasn't an EDTA plasma available, that is when we would perform serum reflex testing. However, now we had some reporting challenges, again, to be cautious. If it was positive, we were confident in the results and we would report it that way. If it's negative, we would actually still request a follow-up EDTA sample to confirm. Now that we've implemented it, we can go back and look at the data. It's something we'll be working on to see if we can, if all negatives were confirmed to be negative, if we asked for an EDTA follow-up, for an example, so we can sort of get rid of parts of this algorithm and be more confident in serum testing. But at this stage, you can see quite a complex algorithm to sort of be on the cautious side. So in terms of implementation hurdles, for us, it's a very complex workflow in SOP, and it took months to work out. So we have to consider that testing history if they were first-time positive or never received an RNA result, as well as what the serology result is, again, reactive on 2 of the different EIA platforms, plus looking at the signals. And at the same time, we're also looking up the history related to other HCV testing considerations, trying to eliminate repeat anti-HCV testing that's unnecessary, looking at patients who may be EIA non-reactive, such as immunocompromised, or having bloodborne exposures that may get an RNA test even if they are non-reactive, looking at the genotyping requests. So it is a 7-page SOP just to accession the samples to figure out what they may be tested for. And it actually involves 3 different labs. So the accessioning lab will do a lot of this lookup initially, and then the sample gets tested in the serology lab. So a separate lab within the same large building, but a separate lab, separate oversight. And then, of course, if it needs RNA testing, it goes to our virology lab, again, separate entity, separate oversight. So then we had all these labs working together through these complicated SOPs. So this is really what took months. And just to give you a flavor, you had all these different steps. So, step 4, looking up a history if there's a previous PCR result. Another step 8, so I've skipped several steps. You know, if there is an EDTA, you know, we will do the HCV NAT on the EDTA. If there is none, this is where you would reflex to your HCV RNA testing as an example. And then through this SOP, you ended up with several different categories, and, you know, it really falls into this category D, where we'll actually order the serum reflex RNA testing. So very complex, and this is what took most of our time, and it was finally implemented in January 2020. Another consideration for us was communication. So we wanted to make sure that our clients' clinicians knew that we were implementing this reflex testing. We always, with any lab changes, create these memos that are circulating. We have an online test menu that gets updated. We performed internal meetings with some of our clinics and public health infectious disease physicians here at the BC CDC. External meetings presented at World Hepatitis Day. And now we're sort of doing more of the academic knowledge translation through conferences and publications, that since we have, you know, more data on its impact, and we're trying to put that data together. And then, so just briefly, I'll show you the HCV reflex RNA testing data that we have to date. And I've separated it out in the years 2020 and 2021, because you can't always trust what happened in 2020, although I think maybe that's true also for 2021 now. But the number of serum reflex RNA tests that were performed was around 1,000 in both years. And so again, these are tests that would not have gotten that RNA in real time, but we would have requested an EDTA sample. And, you know, about 70% of those were positive as expected. And the turnaround time is within the 99th percentile was about 6 days in 2020 and 5 days in 2021. And actually it is a significant difference between 2021. So in 2020, we're probably struggling a little bit more with turnaround time, which sounds like a few days, but again, we have to transition the sample from a different lab, and our turnaround time generally for HCV RNA testing is maybe not as fast as some of the other testing, which is required to be done in 24 hours. But we're actually quite happy with this turnaround time, as we see it's very different from the plasma median turnaround time. Whereas we look at some samples that were collected before implementation, we can see that the turnaround time for plasma samples is about 50 days. So because we have to request a follow-up in most of the time, and those samples aren't collected for a month or two afterwards, and there's quite a large distribution for when we might receive those samples. And again, for some people, we may never receive a sample, and we haven't been able to capture that data yet. We're working on that now. So the turnaround time for the serum reflex testing is really much better in comparison, and gives us a faster result. And next is what we're trying to look at now, is the impact of reflex testing on that cascade of care, to see if we are now losing less people to follow up and are able to diagnose those active infections. So stay tuned for that. And I'd just like to acknowledge Mel Cradgton, who's our medical director and has done a lot of work, a mentor of mine in hepatitis. Another clinical microbiologist, Paul Levitt, who helps lead the high volume serology lab, Sophia Bartlett at our clinical prevention services, as well as several people in the virology, serology, accessioning labs, as it really did require all of us to come together over a month's time to do this work. So thank you.
Thank you very much. Please submit your questions in the chat. I know one question we had for you, Agatha, was about documenting previous test results. You know, has someone been tested for RNA in the past? What is that result? And how far back do your records go, and how complete of information do you think you have to operate on the information available to you?
Yeah, so our records do go back quite a few years. And, you know, we really, if it doesn't go back further than, you know, a few years, we can repeat the RNA testing. We're really, you know, don't need to go back for 20 years or so. I mean, we're just trying to go back for some amount of time. It's okay if we do too much RNA testing. We just don't want to miss people for RNA testing. There are issues always, as some of you know, with lab information systems, that they get upgraded. and they get changed. And that's where sometimes our linkages and lookups differ. And many times it's actually looking up in different versions of lab information systems, which also adds to the complexity. But we can go back a few years, and that's helpful.
Okay. And did you have to make any type of financial or economic case to the administration for moving toward reflex? And can you give us a little flavor of that, please?
Yeah, you know, we didn't really. So because we're in Canada and at the BC, we sort of in the public health lab, I always start the yes, because we're in Canada. You know, we have a global budget for healthcare. So we don't have to worry about those things, fortunately, but we still have you know, our agencies that we have to respond to. So we have to make sure we're efficient, and you know, testing stewardship is very important. But of course, this would actually save dollars down the road, but we didn't have to do the math of what that actually looks like. It's more RNA testing perhaps for us, but really it's only 1,000 samples a year, whereas getting people into care, as you can imagine, would save thousands.
Yeah, thank you. And one quick follow-up about looking back to the test results. So I want to know, is that a manual process or is that automated with computer records?
It is a manual process. And this is the big struggle. And we know that errors can also occur with the manual process. We'd like to sort of create automatic flags, but it's not simple. And as many of you, I think our teams are just stretched for resources. And of course, we implemented it in January 2020, hoping we would perfect things. But since then, you know, the focus has been less on hepatitis and more on our favorite new respiratory virus.
Got it. Well, please hang around for the panel discussion. Let's go ahead to the next presentation, please. Lindsay, and we'll be hearing from Andrew Seaman, Assistant Professor of Medicine at Oregon Health and Science University, United States. We'll be talking about their implementation of reflex testing, including dried blood spot. Thank you. And Andy?
Yes, thank you so much. I really appreciate this, and it's so good to hear the work that Agatha and their team are doing. I admire, and hopefully someday we will be in a situation where we have a public health system as well in the United States. So I'm Andy Seaman. I'm at Central City Concern in Portland, Oregon, and Assistant Professor of Medicine at OHSU. These are my disclosures. And just really briefly, I added a couple quick slides just a minute ago, so just to make sure everyone knows where we are. So we are right here in the top left here, and we have the 4th highest Hep C prevalence in the United States. And then in Oregon, my work is in the Multnomah County in the Portland area, which has about half of the state population. And just to kind of zero in on where we are. So really quick background on Central City. We're a houselessness services organization. We have 2 integrated primary care clinics with mental health and substance use disorder treatment and primary care, and then also supported housing and transitional housing and inpatient substance with medicated supported withdrawal centers, as well as some other culturally specific programs. We have a 26% HCV RNA prevalence. That's been relatively stable, although that number is starting to come down a little bit closer to 20%. And so we have a number of different problems. So this is really, as opposed to a kind of a global or a country or county, district level view, we are a micro-elimination program. And so we were trying to solve for this issue of, once we made a diagnosis for Hep C, what is the process of streamlining the pre-treatment evaluation so that we can really treat people in the moment, or as close to the moment as we can, in this population that is very easy to lose to follow up. So we've had Hep C antibody reflex to RNA since 2016, but we've really had a lot of challenges completing the full treatment evaluation. People would order part of the evaluation, but not all of it. And then we'd get denials from our payers because they didn't have one lab or another. We'd have to get them back. And it was a real challenge. And it's a real challenge for this population to draw blood sometimes, both technically and logistically. And so we collaborated with our lab, Labcorp, lab partner Labcorp, to create a pre-treatment evaluation for Hep C screening in 2018, and we implemented it in 2019. This is what it looks like. Sorry for the quality of the picture here. So we screen everyone in an opt-out fashion coming into our clinic with hepatitis C antibody reflex to RNA, which again already existed, Hep B surface antigen, and HIV antigen antibody. If the Hep C antibody was positive, not RNA as it says here, but if the antibody was positive, it automatically reflects to all of the labs that we use in our center to treat hepatitis C, including the beta HCG if it was a person who had a uterus. And these data were published in the International Journal of Drug Policy last year. So this is the general workflow. So most of the folks who were screened in our program after the bundle was implemented were approached at the time of intake to services. So they'd come in, they say they want to be part of Central City Concern, whether in a health clinic or in a detox center. And then the intake staff, non-clinical staff, would click a button. We would say, we screen everyone for hepatitis and HIV. Are you okay with that? So opt-out language. And then they'd click a button which would order this lab bundle. And then patients would proceed to our internal lab. 100 to 300 tests or so were performed per month. Once the labs were resulted, so this is now between visit 1 and visit 2, these labs generated into the inbox of a Hep C provider. That provider would review all the various things, including liver health and substance use disorder, comorbidities, mental health, et cetera. And then using these labs, which were now complete for a pre-treatment evaluation, we would order the medication so that we could bypass some of the barriers that we have for prior authorization for treatment with our payers, given the fragmented system that we have. And then if things work well, the second visit, really the first clinical visit for the patient, they are ready to be treated. And this is important for a lot of reasons. One of those is that giving someone a Hep C diagnosis, in fact, can cause harm. There are some data suggesting that people who find they have Hep C end up actually using in a higher risk way. Whereas if you give someone their Hep C diagnosis at the same time as saying, hey, we can treat you, let's get you in today, from a even philosophical or qualitative perspective, we find that it's really useful. These are some data that we published late last year. So on the left, we used a multinomial logistic regression model, looking at factoring in multiple different covariates, including where they were tested, gender, race, ethnicity, what kind of tests they were offered, and a couple of other factors. And we looked at the likelihood of progression across each stage of the care cascade. We really wanted to know if there was a benefit of each sort of intervention or an impact of each sort of covariate. We wanted to know where that impact happened. So this is the adjusted analysis, and none of these were statistically significant by whether or not they received the bundle or did not receive the bundle. Although, as you can see, there was a non-statistical trend towards improved movement across the care cascade in those who received the bundle. On the right, you can see an adjusted Kaplan-Meier survival curve, survival to treatment initiation with direct-acting antivirals. The bottom line is before we implemented the bundle. So less people overall were engaged in treatment and also took longer to engage in treatment before we implemented the bundle. The top two lines, the dark line is after we implemented and received the bundle, and the bottom is after implemented and did not receive the bundle. As you can see, there is a shortened time to treatment initiation in the group that received the bundle, although over time, the overall impact of the bundle did not increase the likelihood of treatment receipt. I have to say though, be very cautious in how you interpret this. We have a team of 8 Hep C treatment coordinators and outreach workers who have great relationships and harm reduction skill sets and have just deep community knowledge and engaging people on the street. So if you were to implement this in settings outside of those sorts of resources, I would wonder what the impact of the bundle itself might have in that population. One more slide I just added in briefly, just to get a better sense of what our program looks like overall. So this is our care cascade, just really briefly. Of those who have a positive HCV RNA in our system, in a mostly homeless or recently homeless population, we initiate 93% of people on treatment. You can see we have a significant gap in our ability to get our SVR12 or proof of cure labs. But overall, we do get most people into treatment over time. I wanted to also briefly talk about equity. So we did using that multinomial model and using that same idea of looking at what individual factors predict movement across each stage of the care cascade. we looked at a couple of different things, including race. So in this graph, you see that statistically, there were people who of various races might be slightly more likely to be Hep C positive than others, but there was no difference in treatment initiation. And I think that's the thing we wanted to focus on here. You can ignore the rest of it for right now. We did have some inequity in one kind of unknown or declined ethnic group, which was mostly Latinx or Pacific Islander in completing treatment and completing the SVR12 labs. But as far as initiating treatment, we had equitable access across the board. And you'll see that as every different category I'll very briefly go through, which includes gender. And this is something that you see very often in the literature. Women are less likely than men, or female identifying people are less likely than male identifying people to initiate treatment, as well as to be screened. And with our opt-out practices, we were able to, and some of these streamlined practices, pulling providers really out of the mix by and large, we were able to screen and initiate treatment equitably across our population. And then the same goes for people with alcohol use disorder and opioid and stimulant use disorders. You can see they were more likely to be screened, more likely to be initiated on treatment. And this kind of factors in addition to the opt-out sort of universal practice we have, obviously there are also individual provider practices. Once people do make it into our system, people who are missed for screening are more likely to offer screening to this population, and also potentially more likely to motivate them to treatment in our setting where we really prioritize treating people who are actively using drugs from a public health perspective. All right, so some operational challenges. This requires a lot of blood. And actually, I would say that the way the bundle is currently designed, it requires more blood than is necessary, most likely, if you look at the kind of work that Agatha and others are doing globally. But I won't read all these off, but these are all the different tubes that are required. There is some redundancy, and some of that is because there is some hypothetical, or there's some real risk of contamination when you're doing RNA testing, which we didn't really get into. But having said that, we are working with our partners to try to streamline this process a little bit. So a lot of blood, and a lot of blood is really hard in a population that injects drugs. And then because of that, you really need skilled phlebotomists to do this. So people who are less skilled in this population to draw 6 or 7 tubes, it's a real challenge. And you do get some failed blood draws because of that. And that's a real concern. And then, you do need to have, as far as building this lab bundle, the primary complexity, as I understand it from our lab partners, was figuring out how do you develop systems in a large national laboratory to store all of these various reflex samples and make sure that they're all linked to the initial sample and all of that. So that really is my understanding, was the biggest complexity in developing this test. Otherwise, all of the methodology was already created. So really no specific economic considerations besides really, as Agatha mentioned, that, I think these people are less likely to require retesting, repeat testing in other settings. If you get all of the labs done at once, you're more likely to have that treatment initiation happen in that center, at least, as opposed to maybe losing them to follow up down the line potentially. And repeating these tests as often happens in our healthcare system. And then another problem we were trying to solve for was, how do we do confirmatory testing in outreach settings or in people with difficult venous access? So phlebotomy is very challenging in outreach settings, especially when you're trying to draw a lot of blood, and some of it you have to spin down right away, and some of it you have to freeze quite quickly. The HCV RNA has been available on dried blood spot outside the US for a long time, but it hadn't yet been validated here. And looking at our partners in Australia and in the UK and Scotland and elsewhere, they have a lot more experience than we do with dried blood spot. And so we partnered with a lab close by to us in Vancouver, Washington, to validate the HCV RNA with reflex testing. So the dried blood spot treatment ready card, this was the concept of this was that we were hoping that we could get all of the tests that we needed, with the exception of some sort of fibrosis assessment, to treat people with dried blood spot alone. I didn't show you this here, but we also validated the Hep B core antibody on serum separator cards. And we're not there yet. We can do all of these lab tests. We're not there yet because we still require some fibrosis assessment from our insurers to treat people. Hopefully that goes away shortly. We'll be able to treat some low-risk populations with just dried blood spot alone. So this is what this looks like. Either an outreach worker on the street or somewhere in the community or a homeless shelter, or someone working at an opioid treatment program who also, there are some challenges in implementing phlebotomy in those settings. An opioid treatment program in the US specifically refers to a place that can prescribe methadone. We'll perform this dried blood spot test, or we will have patients self-test, like in our housing programs. So this is a test that, at least in the US, you can perform on your own. There's no sort of requirements around how the test is, the sample is collected. I should say collected, not performed. These aren't performed, it's just a sample collection mechanism. And then we send it out to the lab, and the samples are extracted from the cards. And on the second visit, usually through the outreach worker, we are delivering results and the $15 incentive. So we do pay people who are using this test $15 to get their results. So relaying relaying incentives at the time of results is really important in our model. It helps link people to care. So the impact, we have very little clinical data at this point, but what we do have, this is very recently implemented. We've done 355 Hep C antibody with reflex to RNA dried blood spot tests, and 95% of the antibodies successfully completed the RNA confirmation. The turnaround time was 3 to 12 days. That wide range has to do with early implementation and insufficient volume for the lab to efficiently do this. The more the volume picks up, we expect that the turnaround time will be quite similar to our phlebotomy turnaround time. We don't have our linkage to care data yet. So operationally, training on optimal card saturation is really important. So it's really important that the blood soaks all the way through the card. You can see it on both sides. If you get fully saturated cards, you can get 2 to 3 punches per card, per circle, 5 circles on a card. To be safe, we get 2 full cards, so that's 10 circles, which can also be a challenge. And that's for that entire panel of labs that I showed you. Hand warmers can be helpful, especially if doing this outside and it's cold. It's 17 below here in Vermont right now. It'd be really challenging to do that. Patients need to be hydrated, ideally, or their fingers clamped down. Though we relay the results at 1 to 2 weeks, and that can be really challenging to find people again. So there are some real challenges with any lab test in the community when you don't have a fixed structure or a place where people are coming repeatedly to relay results to. And then still, we need some liver assessment prior to treatment. So they still need to be linked to phlebotomy. So another issue there. So economic considerations really similar. So the cost for these labs is very similar to the phlebotomy equivalent, and they don't charge for the RNA test if the RNA test is not performed. It's charged at the same rate as the Hep C antibody. So some summary of some of the benefits of reflex testing. I would argue that lab-based Hep C antibody testing really has no utility anymore. I think we only do that in a setting where we don't have enough sample to complete the RNA. Hep C antibody rapid testing in the community still probably has a role for some people to motivate people to complete the process, but lab-based testing, I would argue we should just really do away with altogether the best we can. Primary operationally, the lift is that you really need to figure out how to store all these samples and avoid, specimen contamination, and when possible, really encouraging everyone to figure out how might we streamline the blood volume, because in the community, in the clinical perspective, it's very difficult to get this much blood sometimes. And DBS is helpful to enroll new places or new potential touch points of screening for hepatitis C that are really not feasible to implement in purely phlebotomy-based screening. And if you do have someone in a health setting, we really, our qualitative experience, especially with the single draw lab bundle, is really helpful. And I encourage people to think about adopting this. This is publicly available in the United States with Labcorp, and we certainly can share the way we have done this to more detail. This is my contact, and I'd love to stand for questions as well.
Thank you, Andy. Excellent presentation. Please submit your questions and comments in the chat or in the Q&A function. You raised a number of important points and a number of innovative strategies, particularly around dried blood spot testing, which is, as you mentioned, not well established in the US. But being a clinician with personal experience of challenges in getting venous access and people who inject drugs, and you mentioned the large amount of blood you're seeking to collect. What's the sort of the fallout rate, or what percentage of people that you try to do reflex testing on to get that amount of blood, but you're just not successful because of poor venous access in your patient population, and therefore really revealing the value of a dried blood spot option?
I don't have that specific number. I would estimate it to be somewhere around 5 to 15%, depending on where you are. So if you're in a medically supported detox center and people are sick and dried out and dehydrated, it's higher. If you have been able to prepare people or they're housed and well, you're more likely to get the specimen. I think that often though, that number, which is in our clinics, probably closer to maybe 2 to 5%, probably is lower than it would be, in that a lot of people who have difficult venous access just don't go, right? They don't get their labs done. And so we wouldn't even know what the ultimate result is. I will say that a lot of people have started opting to dried blood spot even in the clinic setting because of that. And people who we formerly used to send out to a hospital where they could do ultrasound guided phlebotomy, we are now doing with dried blood spot first to at least confirm the diagnosis. So okay. I don't have great numbers, but it's certainly useful.
Thank you. Also, your relationships with Labcorp, which of course is a national laboratory, and I assume you're obviously working with their local affiliate in their area. Did you have a sense that this was already routine practice for them, or did they establish something specific based on your request for your clinical setting?
So the reflex RNA was routine practice. This lab bundle was all co-created together over the course of about a year, and it actually had to work its way up to the national level to get approval. It is not actually yet routinely available on their lab menu, although they're working on changing that, but anyone can order it with the test code, which I'm happy to also provide.
Okay. And is dried blood spot testing option now routine for your clinical setting?
Yeah, so we use it as a routine hybrid option. So in all of our outreach settings, we use dried blood spot. In the opioid treatment programs, we use dried blood spot. In the clinic, it's available as a secondary option, guided by our Hep C coordinators, but it's not available in the lab because they're separate. The lab is run by Labcorp, and dried blood spot is really run by us in collaboration with another lab. But it is routinely available for those who want it.
Okay. The other question came to mind for me, you did touch on a home test option, which is really gaining a lot of steam. That Philippa might comment on this as well. And just wanted to see how attractive of an option would that be for your patient population, compared to these other options that you presented today.
So in our population, we use it only in our folks who are in supported housing. And we do that because it's the only population that really has a safe place to be, or one of the only populations. And, I think it's attractive. It's getting off a little bit slow. Again, a lot of this we're implementing during COVID, so it's hard to really assess overall what the appetite is. I do think that broadly speaking, though, substance use disorder populations who are housed, I think it'd be very attractive to be able to send these labs in the mail to folks. And that's something that the lab we've partnered with actually really specializes in. They do molecular testing labs, does a lot of prep work. So they sent people who are on pre-exposure prophylaxis for HIV, they'll send these lab panels to people to do in their home, in the community, and that is widely accepted. So I think if you could communicate this to a broader population of people who use drugs and get this out to health systems, that a lot of people actually would opt for self-testing.
Excellent. Thanks again for an excellent presentation. And again, please hang around for the panel discussion. Let's go on to our next presentation, which will be given by two our colleagues, Ruth Simmons from Public Health England in the UK, and William Irving, professor and honorary consultant virology in the University of Nottingham. I guess, Ruth, you'll kick us off?
Yes, thank you. It's good afternoon from here, but good morning, everyone, from wherever. Thank you for the invite. I am an epidemiologist at UKHSA. We were previously Public Health England, but we're now UKHSA. And I am one of the surveillance leads for hepatitis for England. And as I'm not a virologist, and there may be questions, I did phone a friend and ask Will to join me for answering any questions, who, as you said, is a consultant virologist at the Nottingham University Hospital. So I was going to give a England perspective on hepatitis C reflex testing. Next slide, please. So I think we've already kind of distinguished this already, but as we know, Hep C antibody testing doesn't distinguish between your current and past infections, and a RNA or an antigen test is required to determine the status and then also ensure linkage to care. So there are a number of guidances out there. So WHO, NICE, and in the UK we have our own about screening for hepatitis and looking at single assay testing or reflex testing with a RNA done on the same sample as the antibody. And our standards of microbiology investigations also provide a resource for commissioners to ensure appropriate microbiology investigations are available that should be part of clinical and the public health package. Next slide. So the WHO guidelines, as I said, with the testing show a single assay, so testing anti-HCV, which would, of those who are positive, results in an RNA test. And then next slide. Our UK standards for screening for Hep C suggest the same, with HCV antibody, and those that are reactive have a RNA test on that original tube. Next slide, please. So in October, and I think this was stimulated by conversations with John and the team, we did a rapid survey of our UK NHS laboratories to understand their testing practices. So labs were recruited through the UK Clinical Virology Network, of which 26 responded. And we sent out a questionnaire with seven questions, which were completed by those labs. And so we asked questions such as, does your laboratory undertake a reflex test, RNA reflex test? Does your laboratory undertake an antigen reflex test? We asked about barriers to undertaking reflex testing. And then we asked about frontline testing for whether this is done for RNA and antigen, whether there were the platforms to implement antigen testing, whether the laboratory tested dry blood spots and whether they undertook reflex tested on the dry blood spot tests, and then does the laboratory add any commentary to the result indicating the need for referral for treatment. Next, please. So as I said, we had 26 responses, of which the majority indicated that they did do reflex testing or they did antigen testing. The majority indicated that neither did RNA or antigen as a first-line test, but 10 of the labs indicated that they had a platform available to do the antigen testing, of which one of them was already doing first-line testing. The reflex testing on dry blood spots was very mixed, with only 8 of the labs indicating that they were doing reflex testing on dry blood spots. And the majority, bar one, provided commentary on the results to indicate linkage to care. Next, please. So I've summarized some of the barriers that were reported, but the key ones to highlight were the sample volume being sufficient to do the reflex testing. There were budget, funding, the contracts, etc., how it was commissioned, whether the service requesting a test, requested a reflex test on the anti-HCV, and also the question of plasma versus serum and whether the sample was coagulated or not. And this comes up quite a lot within discussions in laboratories. Next, please. So that was a survey to give an idea of the coverage of testing within laboratories within England. What we can also do from a surveillance point of view is look at the data that comes through. So the UK hepatitis surveillance, regardless of B, C, or A, is predominantly led by laboratory testing and laboratory data. So all of our data is baseline laboratory data that we build up on. So in the UK, HCV testing is mainly done in public laboratories, so NHS laboratories, and testing is free of charge, and there is a small contribution of testing by private laboratories. So we have two main systems to work from. So we have SGSS, which is England-wide routine system that automatically extracts positive diagnostic testing on all notifiable organisms from the laboratory information management system. So every day it sucks out any positive results from that laboratory, and then the specific teams get their hepatitis their specific organism data. So for us, it would be hepatitis. We also have Sentinel Surveillance of bloodborne virus testing, which has a number of laboratories. It's been going since 2002, has a number of laboratories that report tests regardless of results. So we get both the positive and negative results and any additional markers that are done for those individuals. So we can start to build up a picture of reflex testing with these data. And on top of that, we also have the Hepatitis C Treatment Monitoring and Outcome Registry, which has been live since 2015 following the introduction of direct-acting antivirals. And this is a repository where all individuals who are accessing care, what treatment they are accessing, and their outcomes are all entered by the delivery networks across England who deliver the treatment. So just to note that UK HSA has the legal permissions and mandate to collect and process patient confidential data on notifiable diseases. So we collect information such as name, NHS number, date of birth. An NHS number is a unique number for an individual, and we can do this without consent for public health methods, so such as surveillance of communicable diseases. Next slide, please. So having a look at Sentinel Surveillance, so this is within this one, it's 19 labs, so across England. We looked at reflex testing over the last 5 years. And so we classified reflex testing as a RNA or an antigen test within 1 week of an anti-HCV. Now, we did look at timing of tests, and we found that a week really did hone in on that reflex test with nothing gained by extending it past 1 week. And so between 2015 and 2020, we had just under 3 million individuals tested for HCV. Through 19 laboratories, of which 61,000 were identified as anti-HCV positive, and that's a test positivity of 2.2%. And of those individuals, we identified that 70% of them were reflex tested, with 8% RNA tested, RNA or antigen tested, between 1 week and 6 months, 1.5% between 6 months and 12 months, and that 1 in 5 had no RNA tests within 12 months of their anti-HCV positive test. The proportion of reflex testers has increased over time. And so from 2015, it was about 70%, and we're now at 2020, we're at about 84% of tests being reflexed. And when we looked at this a couple of years ago, pre-pandemic, we looked at data from 2008 and 2013, the proportion then that were reflex tested was 52.7%. So we're increasing all the time. The median time to treatment following an anti-HCV positive result was 83 days for an individual who was reflex tested compared to 214 days for a person who was non-reflex tested. And just from the conversations, I haven't included it in this in the slide, was just about the DBS versus venous testing. And there was a very little difference in the proportion reflex tested with the two different methods, with DBS testing having 75% reflex tested, with venous having 69%. So very, there isn't a difference between the method of test. Next, please. So looking, we thought we'd do a sort of cost comparison of the different pathways, looking at a reflex pathway versus a non-reflex pathway. And I've highlighted in green the additional costs that are occurred if there is a non-reflex pathway. So I've done 3 different possible scenarios that we would consider within the UK. So having your anti-HCV test, and then for those who are anti-HCV positive, either being asked to attend for a further phlebotomy appointment for additional bloods for the RNA test, whether they would then be perhaps called in to see a general practitioner, have an appointment and have additional bloods, which on average is about £30 with the £5 phlebotomy, or the more expensive version would be to have an outpatient appointment with additional bloods, which on average was about £120 with a £5 phlebotomy. So the additional costing of having a non-reflex pathway ranges from about £64,000 to £1.5 million additional to your reflex pathway. And that's estimated using just 2019 data that was reported to Sentinel Surveillance. Next slide, please. So to summarize, there are variations in reflex testing, commissioning and provision across England. There are still barriers, which include the sample volume and inappropriate samples to conduct RNA, such as the discussion about serum and plasma, and testing being requested by the external services. The proportion of test reflex over time has increased, which is a really positive, and a reflex test is associated with earlier treatment. Efficiencies are gained by moving to reflex testing by preventing unnecessary appointments and multiple positive anti-HCV tests. I looked over our previous analysis. I didn't get a chance to do it for this, but of those anti-HCV positives, 13% of them have multiple anti-HCV tests before getting their RNA test. So that's an even more additional cost additional to what we have already discussed. And there is a need for, sorry, I just want to read what I've written there, and there's a chat's just popped up. Sorry, just waiting for that to disappear. So there is a need for the co-commissioning of testing, treatment and care based on a HCV diagnosis rather than component test result. Next, please. So I just wanted to say thank you again to the labs that very quickly answered our rapid questionnaire in October. And then also next, say thank you to the hepatitis team and those involved in the work, and also to thank the lab staff who continually report to Sentinel Surveillance that keep the program going and is fundamental to the work we do. So thank you very much.
Go ahead, Bill.
I don't have anything specific to say. I'm here in case somebody throws a wobbly at Ruth.
Here is my virology backup. So thank you. Any questions? I'll have. I don't know if there were any. I'll have a review of the chat and respond.
Well, there was one question from you regarding a SNAP survey regarding lab testing. Would those questions and results be available publicly? Are you familiar with the SNAP survey?
The SNAP survey, not so much, because that comes into us. We manage that, but the questions can be shared, and I assume other teams will have versions of the SNAP survey that they could develop to send out across. So yes, that would be absolutely fine.
Yeah. Well, thank you for doing that survey. It's very, very informative. With the barriers revealed, are there efforts underway to seek to remove those barriers, or you think you're reaching sort of the ceiling of what you can expect for adoption of reflex testing in the UK, or you think there's still some areas for improvement that's possible? Bill?
Yeah, I think the identification of the barriers was very interesting and very important. And I also find it very frustrating that there's this issue over whether you should test serum for RNA. And I thought Agatha's data was fantastic. You put a lot of work into this, but we've always tested either serum or plasma for RNA. And it's frustrating that labs, well, it's not their fault. It's because the kit manufacturers specify what analyte they are allowed to use, and the machinery manufacturers also say what kind of tests are permissible on their machinery. But in reality, as Agatha's data showed beautifully, there is no reason at all why you shouldn't use serum to do an RNA test. And I guess we need to get the message out there, whether it's to the kit manufacturers or the equipment manufacturers or just the laboratories, to say, stop worrying about this. If you receive serum and it's anti-HCV positive, just do the test.
Yep, excellent point. We get we get Philippa involved in this, and she can make some comments. Then we can open up that type of question to the panel overall. So Philippa, it's great to have you on. Who's with the WHO in Geneva, and has been very heavily involved in this. These case studies is part of a larger effort to build the evidence base for WHO recommendations to simplify testing. So Philippa, I'll turn it over to you for your remarks. Thank you.
Thank you so much, John. And I think this is really a very useful session. It's so important to have a dialogue about the how to implement these interventions. And I think we've heard a lot of useful stuff, the three presenters. So I was just going to sort of reposition this reporting experience in the context of planned updates and ongoing updates to the WHO global guidance. For those of you familiar with our work, we have had guidance for hepatitis C treatment. We have had guidelines on hepatitis B, and we had testing guidelines. And so we've been systematically working through key topics to update. And then our overall aim is to then consolidate both the existing unchanged recommendations with new updated ones into a consolidated viral hepatitis B and C testing, treatment and prevention guidance by the end of the year and into 2023. So in terms of hepatitis C, which is what we focused on last year, we had the self-testing guidelines that came out earlier in the year, that John alluded to. And then most recently in October, we focused on the topics of simplified service delivery, decentralization, integration, task shifting, reconciling the adult recommendations for SOFT-ACT, SOFT-L, and GP, for also treatment of children and adolescents. And then we included a number of topics on the diagnostics point of care viral load, as well as promoting other strategies to promote linkage. And one of those topics was, of course, the reflex testing. Next slide, please. So this is zeroing in on the interventions to promote uptake and linkage. And what I've listed there in black are the existing recommendations we had. And what I've highlighted in the red bullets are the new topics that were part of the October guidelines update, because it's very important that, you know, these interventions are not seen as in isolation, that as was alluded to by Andy with his nice sort of bundle of the bundle of the lab tests, we also seek to encourage countries to bundle some of these different interventions appropriate to their setting, because we're looking for marginal gains and sometimes big gains with these interventions. So I think that this just summarizes, you know, what we already had was promoting integrated testing and treatment as part of linked with substance abuse services, for example, where we were promoting peer and lay health worker support to promote linkage and clinician reminders. And we already had a recommendation on dry blood spots. What was new was really promoting simplified, decentralized testing and treatment. So that means testing and treatment where possible at the same site and even on the same day. The use of task shifting to non-specialist workers and primary care physicians as a vehicle to implement decentralization, and then also the additional option of point of care viral load testing and the question of reflex viral load testing. So it's just helpful to give you that overall framework of how and where we were positioning the reflex testing as part of other interventions. Next slide. So I think I'm not going to show many slides, but again, just to put things in context, first of all, just on the decentralization and integration, essentially with a review, systematic review that was published in Lancet Global Health of more than 140 studies from globally, the demonstration that when you have testing and treatment at the same site, so full decentralization, whether or not that's integrated at harm reduction sites or in primary care, showed us, you know, a significant impact on uptake of viral load and uptake of treatment. So probably about a 20–30% improvement. In addition, a further intervention, that's the use of a point of care viral load. And I would say that was the majority of the, 45 studies we had, about 60–70% of them were among persons who inject drug or homeless populations, as well as prisoners, far fewer in the general population. And again, this just summarizes the findings there, showing an impact on uptake of viral load testing and to a lesser degree uptake on treatment. And this was particularly noted in the PWID homeless population. So another intervention, another gain. So now turning to the reflex testing, and you've heard, next slide, please. So you've heard the great profiled examples, and this was a very important part of our guidelines process that John and Lindsay led at the task force, was pulling together the kind of programmatic description of how this implementation of the reflex testing was taken on. And in addition, we undertook systematic review. And so I'm just going to, as a complement to the experiences you've heard, I just wanted to flag the take-home messages from that. So there were 51 studies, and 32 of those were lab-based reflex testing. So that immediate sort of prompt for the use of an existing sample collected, so a single visit for the patient, and then reflex testing on that's that additional split sample or second sample for a viral load. So that accounted for most of the studies, and it's fair to say that the majority of those were in high income settings. In addition, and of course, WHO guidelines particularly are catering for low and middle income countries. We also looked at the issue of clinic-based reflex testing. That is when you have an RDT done at a site and there's a positive result, ideally within 15 minutes, and another sample is immediately taken, either to be sent to the lab, or if you have a point of care viral load on site, again, moving immediately to doing a viral load on site. And we had about 19 of those studies. And I think a big, another important feature is that in both those populations, that's the lab-based reflex and the clinic-based, a high proportion were in PWID populations, more in the clinic-based than in the lab-based. And in addition, that we had 10 with comparator studies in the lab-based reflex, but we did not have that in the clinic-based. So next slide. So what were the main messages? Well, this just shows across the lab-based and the clinic-based what the overall uptake was. And remember, this is without comparator populations. So, and it's a highly selected, there's a publication bias to some extent with this of those who are reporting their results. So a pretty high uptake of RNA testing, less so on the linkage to care, and then, as one might expect, because particularly lab-based reflex testing has little impact on how good your ultimate linkage to care and treatment is. So there's a drop, but with the clinic base, those starting treatment who had the reflex clinic testing did quite well, so maintained across the cascade. So it's quite interesting to look at these differing models of reflex testing. And I think they are both extremely useful, and when they're deployed in the right setting and the right context. And then the final slide was really just to show in the lab-based reflex studies that had a direct comparator arm, this is how it looks on the forest plots for uptake of RNA testing, linkage to care and treatment uptake. And again, as you would expect, the biggest impact and that was statistically significant was on the uptake of the RNA testing that we've seen in all the projects that have reported today, and a little rather less impactful with the treatment uptake, which is rather removed from the lab control. So I think coming out of this, we see lab-based reflex testing and indeed clinic-based reflex testing as a kind of low-hanging fruit, straightforward intervention that really should be, part of a critical package of interventions to promote uptake across the cascade. And I think, not only was there the impact on the outcomes, but the examples that were collated by the task force really were demonstrating the programmatic feasibility. I think the NICE data from Public Health England on some of the cost savings was quite compelling. And of course, the attractiveness to the patient and the healthcare worker in terms of avoiding venesection. So I think I'll stop there. And if I may, John, just perhaps pose 3 questions that I think, came out of the presentation that really, for me, prompted some questions. The first really being about the contamination issue, which obviously was a kind of a concern that was brought up in our guidelines meeting, but largely seems to have been addressed, and the greater adherence to a second sample that's stored in a different location. But it would be good to hear from all the presenters about how they sort of view that. And linked to that, and that comes up from Andrew with his bundle and having all the labs at once, how that would play out in some of the other labs that are largely virology, molecular biology labs, and not on the chemistry and the hematology, and how much of a kind of logistical challenge would it be to have a selection of samples that have to be fed into different parts of the lab, waiting for the viral load confirmation to come through. And then I think to Andrew, really just about, I know gene expert and other point of care viral load has not yet, had much of a presence in the US market. But for your model, where you've adopted this simplified and bundling the lab approach, how would you see having a finger stick, RDT followed by a point of care viral load? Would that be a preferable approach to the one you're sort of espousing? And I had a question for, I think—
Let's hear a response to that one first. Let's go ahead.
Okay, sure.
Please. Okay. Andy?
Yeah, so the response to the latter question, so absolutely, I would love to get my hands on a gene expert or any other point of care RNA test that had a high enough specificity to initiate treatment. I think that from our population perspective, and really the whole rationale behind the lab bundle, is that when someone is physically present, we want to be able to offer treatment. And that anytime you require another step in the process, as we've seen over and over and over again in these implementation studies, you lose people to the care cascade, especially in my population. So, if we had the ability to do real-time viral load confirmatory testing, we would probably be able to increase our treatment initiation rates in some of the outreach populations that right now, I couldn't break down those data for you, but right now we're seeing definitely early on with DBS that we're losing more of those folks. How many of those people will recapture later, it's hard to say, but I think the other challenge, of course, is that you also then, at least in some settings and for some individuals, have to figure out how to do at least some assessment for decompensated cirrhosis if we don't really need to know about cirrhosis as far as treating hepatitis C anymore. And that, I think there's probably ways to address that. I know that there are some example studies that were presented at INSU this year, and some of those are in publication that looked at, really high treatment initiation rates and people using things like just clinical prediction rules to determine who you could treat without further assessment, who maybe you had to get a fiber scan or something like that on. But there are some additional challenges around that. But I do think at least some substantial portion of, younger, healthier people, you could just treat with just that point of care test. Ideally, also, I know there's a big project out in Southeast Asia that they also had access to point of care Hep B testing. So that's another thing that you might have to sort out in higher Hep B prevalence areas to make sure we don't have that reactivation issue with hepatitis B. But the summary is I would love to see point of care testing.
Excellent. Thank you. Agatha, Ruth, I didn't know if you had any other comments on that question.
I can speak to some of the work that our clinicians in BC are doing, but I'm not directly involved in as I'm in the public health lab on some of the initiatives that have more point of care RNA testing. But I know that we have had gene experts and point of care tests piloted at certain sites where we have large populations of priority populations in our downtown area in Vancouver. And I only add the one other thing, and again, this is what I'm hearing from them. I don't personally have the experience, but that even a gene expert that takes an hour to give you a result is sometimes too long. And the person that comes to the clinic actually leaves within the hour. And it's just an interesting challenge. I don't know how much shorter we can get unless we eliminate amplification with some other methods down the road, but that was an interesting thing to hear on our end.
Thank you. UK, Ruth, or
So there are initiatives using, so I think the majority of the time it's the KEFID machine. So that's been put into prisons, and also I think it's being used, it is being used on the find and treat bans where they're taking the ban out and testing the populations such as homeless populations. And I think that's still a half an hour wait for the RNA result, but it is being used within the UK. I mean, I think it comes down also to Agatha asking me questions about how we then get that data fed in. And we do work hard to try and set up those conversations with the stakeholders, but that is one of the difficulties of, the point of care test gets us that step further, but it's, do we then have a gap in the data, and how do we manage that? But yeah, I don't know if you have anything to add. The KEFID's the only one I can think of, the big one.
So we have started what we call HIT, H-I-T-T, high intensity test and treat. program in our prisons. So a team will go into a prison armed with a Kefid machine and a whole pile of cartridges, test the entire prison on a sort of micro-elimination aim, and start treatment same day. So it's doable. Obviously in prison, it doesn't matter if it takes an hour or an hour and a half because nobody's going anywhere. But that's where we've started with point of care testing.
That's great. Look forward to hearing more about that. We hope to have a webinar on incarcerated settings later in the year. We'll cycle back to you on that. Philippa, what's another question you have, please?
Yes, the question was, I suppose it relates to Agatha and to Public Health England, given that we're now seeing in quite a number of countries that there's a tranche of people who just never got linked and never got treated, who may or may not have had a viral load test. So excluding those who've had a previous viral load test, if they've not been treated, and often I guess the lab would not know that, would seem a missed opportunity if they've been retested. So I suppose, it's how do we capture those or not exclude them? And yes, it'd be good to hear from Public Health England about the strategies to refine those who tested, but who may not have had a viral load test. Well, some of them did, but it's an opportunity to capture them again.
So there's quite an extensive model of what we're trying to do for doing that. So before the pandemic, we actually pulled out a line list of everyone who had had an anti-HCV positive test since the beginning of time, and we worked very hard to identify, to see if they'd been treated, see if they were still alive, etc. And we shared those across England to the operational delivery networks who are in charge of providing treatment for them to use to follow up with their GPs or do local searches for individuals to whether they've been tested recently, etc., and what their status is, and then to invite them back in to be retested and to identify what their current status is and be offered treatment. The other things that are also being looked at are, we have been looking at more evaluating, sending out tests to GP participants. So that's just about to go live. So we've got a list of individuals from a number of GPs where we are going to send them a letter asking them if they would like to take a Hep C test. So we're doing that in the older age groups, thinking about the baby boomer kind of that the unknown unknowns is what we call them, so not the low-hanging fruit within the drug services, etc. And then also we've been working with NHS England to develop a dashboard, so more aggregate level, so looking at numbers of people testing and where there may be gaps, but also we've just recently started to push. We've just sent out data sharing agreements with them to pilot whether they can send us line lists of people they can't find, so we can use surveillance data to try and identify whether maybe they're in a different area, but also then to help identify those who seem to be lost to follow-up, or again, they may not know them and they've been tested. So really trying to share the data and use the data in a way that can identify individuals to push that forward. I think hopefully covered most of the, some of the initiatives anyway.
Yeah, good overview. I think I know we're coming right up on our 90-minute time. We can go on for a few more minutes, but recognizing we do have an evaluation set of questions that are popping up on your screen, please complete those so we can continue to improve this webinar series. I did want to let people just be aware, Lindsay, if you can put up the slides about, we do have a collection of data from around hepatitis C testing on the coalition website at globalhep.org regarding, have a systematic review on testing, our webinar series, budget-based planning tool to plan for hepatitis testing strategies. We're developing a collection of national hepatitis elimination profiles with 35 countries that have hepatitis data in there, and we continue to build on that data set and to go to our site to look for that. If people want to stay on for a few minutes, we still have a good number of the people who signed on originally still with us. So Philip, I'll turn it over to you to ask your last question, because it sounded like you had 3.
I thought I'd ask them all.
Okay.
But I suppose it was for Agatha to respond on the earlier point. And also, I was waiting to hear about the contamination issue. It seems as though it's been partly responded, but whether any of the other panelists wanted to comment on that.
Yeah, I mean, I can start on the contamination issue. So we're talking about RNA contamination. Correct, yeah. And you know, it was interesting because, you know, every 3 years or so, our contracts with our vendors are up, and we go through a procurement process to, and often we've been actually changing our manufacturers, and every time we change, there's slightly different performance. But you know, and we know that's going to happen. But it was a big shift 3 or 4 years ago when it was our last change, where, you know, our RNA testing was performing quite well, and then we actually did come across some contamination problems. One of the problems was that we find some manufacturers include UNG, which you know, helps take uracil off RNA and prevents sort of contamination issues, and others don't. You can add that in, for example, so you can add it, you know, sort of try to artificially not artificially, but add in some reagents to try to eliminate contamination, and labs can try to do that. For us, it was really just working on our quality of lab workflow. And our labs were designed in the 90s, which sounds recent, but even then we didn't have that good directional workflow. And so we really had to work on establishing a good directional workflow for one. We do things like switch lab codes before going to that area, you know, from an accessioning sample processing area to the amplification area now. And also we have an in-house genotyping test for HCV. And that has to be performed in a separate area, because then you also, you know, are having amplification of HCV from 2 different processes. So it was really working on directional workflow, wipe testing, et cetera, and just becoming familiar with new instrumentation. But I feel like that happens every time we implement something new. But we have been able to you know, get rid of contamination. We don't think that's a problem. The challenge is, how do you monitor it going on? And for all of our tests, it's really about looking at positivity rates and values and having these quality metrics. So not just how your controls perform, but how many of those less than 10 or less than 12 IU per ml samples are we capturing? And trying to figure out, is that actually related to that patient? Are they in the process of clearing? Or are we just seeing this high potential false positive rate? And so linking to the patient demographics is important for us. And it's hard to establish those quality metrics routinely. And I have to say, when it's not fixed or when it's not broken, you're not really looking. And we're mostly focused on putting out fires, but we're trying our best to keep an eye on it.
Thank you. Will, do you have a comment?
Yeah, I was just going to say, I think the introduction of real-time technology has reduced the risk of contamination considerably, because essentially the reaction is now taking place in the closed tube, and you're not opening the tube to run a gel, and that's the step at which you contaminate the atmosphere. So I think, as Agatha says, workflow, direction, real time, without ever opening the tube. You know, it would be foolish on me to say that contamination has completely gone away. It would be I'd be a hostage to fortune then if tomorrow we got a whole pile of false positives. But it's not the problem it was 15 years ago, absolutely. And I guess at the end of the day, if you have results that don't make sense, especially low positives, you have to go back to the patient and get a second sample. You've got no other way of knowing, because you can repeat a low positive, but it might repeat negative, but that's biologically plausible. And you can't, you know, you could toss a coin and take 2 out of 3, but the way to do it is to go back to the patient, get another sample.
Yep, thank you. I think really, thank you for those comments about contamination and that, you know, they're not quite the issue they once were. I think it's really important takeaway message here. The other group that gets tested that comes to mind for me are persons who are at high risk for new HCV infection. You know, how do you, is there any way to sort of tag those, some of those come in for testing and they're found to be antibody positive? Is there any prompting to test them for RNA, or do you just, or do clinicians have to order both tests, or how is that addressed? I'll start with Agatha since she's nodding her head, and then we'll go around the table.
Yeah, and I think I might have missed this too, so I'm trying to follow all the questions, but it did come up. And, you know, we're very fortunate and unfortunate for centralized testing. Because we perform most of the antibody testing, and because the other labs that are currently performing it are on the same lab information system for the most part, we are able to capture first-time positives. And just by looking back the history. So the clinician doesn't have to order the RNA reflex testing. We can just look back in our lab information system for years and see if they've ever had an RNA test or if this is their first HCV antibody positive test. Now, they may have gotten an antibody test out of province, you know, or years ago, but that's okay. But it helps us really identify those persons quite easily. Now, there are other labs outside of our lab where we don't capture their data, but we have a good working relationship with them. So again, through all of the communications we did, you know, we were able to talk to some of our health authorities that are quite distant from us and told them that we were implementing reflex testing. And they said, okay, well, if it's a first time positive for us, you can't see that, you can't do the lookup, but we know that we're trying to do this now collectively in BC, so we will send you that sample. We will look up in our system, and that's really only in a couple of regions. So it's just having that good communication and being able to look up for years in our information system that helps us identify this. So we take it off for the physicians don't have to worry about it.
Any other thoughts about the testing for acute HCV?
It would be really nice to have a test. That's what we really struggle with, is getting incident data as opposed to prevalent data. You know, we've tried all sorts of things, but it's really difficult to identify an acute infection. Could I ask Agatha, because you're doing all this back checking of previous tests, if you've got a sample from a patient who's antibody positive and previously tested RNA negative, does that mean you wouldn't repeat the RNA? And in which case, how do you pick up reinfections?
That is a good point. We wouldn't necessarily in that case. And, you know, it would be a good population to capture, but as you can see, the workflow becomes so complex and so many areas to look up, and, you know, medical lab technologists have a lot on their plate. So that would be up to the physician. I think we try to help where we can, but we're also trying, you know, to be stewards of lab testing. So we wouldn't necessarily test those. Yeah.
I can weigh in briefly about the acute Hep C piece. At least locally, you know, recommendations would be to, if you do suspect acute Hep C, to do in parallel a Hep C antibody and a Hep C RNA, which of course isn't going to clarify in all situations, which really, again, I think is the one utility of a Hep C antibody in a centralized lab setting. Otherwise, I think getting to the question that Felipe put in the chat, I think, you know, one of the ways that I think we might promote HCV RNA testing, one is to look at, you know, the data like that Ruth presented, that it's more cost effective and cheaper to do overall, but then also then to, if when possible, take provider error out of the equation and take the HCV antibody off of the ordering forms. And you could maybe still order it, but you have to search for it. I think that's like the low hanging fruit. It's hard to educate people on appropriate testing schemes, but if you just take the antibody off, only have reflex testing. And then if you really think you need a test for acute Hep C, you got to search for it. You know, like a lot of times we have these, you know, common tests that are ordered, and then you really have to look for the ones that really should not be ordered in common settings. So that's one sort of logistical thing that I'd recommend associated.
Now, if I can just comment on that, one of the issues is, you know, from a lab perspective, is we do get samples from clinicians that have sort of ticked off all the boxes. Is I want antibody, I want PCR, and I want genotyping, because, you know, if it's positive, they want to make sure that those get ordered, and I understand that. And of course, capturing the acute cases is really difficult, and we won't do it in most cases if the EIA is negative. However, what that means for the lab is it's nice because you've got all the samples and you have all the orders. So if the serology is positive, we can go ahead and do the reflexing and they're ordered and it's not going to get mixed. But if it's negative, we actually have to go individually and reject the samples because we have now accession, then we know they're there. And, you know, again, the complexity of workflow, because we try to limit sort of unnecessary testing. It's hard to manage in all the ways. Yeah.
Thank you. A great layout of the benefits and the considerations for implementations. I want to thank you all for a great set of presentations. Boba, thank you for coming on. I think, you know, I wanted to end with some of the questions in chat regarding promotion of reflex testing more broadly within the countries represented here, as well as globally. You know, it's sort of my perspective that in many countries, you really need a mix of strategies, and lab-based reflex testing being one, because people are getting tested in those settings where that kind of strategy makes sense, in addition to the other strategies we touched on. So, Philip, I'll just turn it to you to sort of end with some global perspective on how you think your guidelines are promoting reflex testing in laboratories, or what else can be done to, you know, for that promotion, including laboratory systems, multinational laboratory systems that we could begin to have outreach to promote that adoption.
Sure. I mean, I think I've said for some time that the Achilles heel in many countries' sort of hepatitis response is that they've not often integrated the testing policies and approaches and diagnostic strategies as part of an integrated, ideally Hep C and Hep B. And so it's kind of left to one side. And so I think that is hugely important, that as people move forward or countries move forward with their national strategic plans, that there is an integrated testing and treatment. And so they really think through, you know, where they're going to position their high throughput instruments, where the positioning of the point of care, embedding the reflex testing as an integral part of that. So I would see that as key, and encouraging that joined up thinking. And then, you know, really all the good practices and examples, you know, to have those case studies on hand, so that, you know, there are some good SOPs of how to implement. And in the original testing guidance, we did have a chapter, a section on the steps for countries, you know, 6 steps, I think, on implementing your testing and diagnostics. I think that needs refreshing. And it's the sort of thing that would be a very nice policy brief and, you know, toolkit going forward, and particularly now we've got these new tools. But, you know, in low-income countries, it is in general going to be the clinic-based reflex testing that is going to be accessible and something they can implement now. And many have, you know, because it just makes sense. And in the lab one, I mean, there are, you know, quite a number of low-income countries that have got, you know, central large labs. And I see no reason why this should not be implemented. And this can apply to Hep B as well as Hep C as well. Yeah, thank you.
No, I agree. And maybe that's, oh, go ahead. Yes, okay. Yeah.
You know, is it Will or William? Is it Will?
Will. Yeah.
Will, you mentioned something really interesting, though, that I want to point out, and I hadn't thought of, is actually having the conversations with industry. Because many of us labs, you know, are tied to, or it's much easier to adopt testing where a sample is already, you know, the preferred sample or the recommended sample for testing, and where serum has traditionally not been. And like you said, Will, I think that's a major cause of the delays. So having those conversations with industry and having that push for more information from them in their package inserts, et cetera, on the serum, I think would be helpful for labs.
Yeah.
No, I agree. I think that's one area that perhaps the coalition could play a role in some of that convening and maybe helping Philippa and the WHO update some of these. These case studies can definitely help update some of that technical guidance and that Philippa referred to. So I think those are two big to-do items that can help promote adoption more broadly. I think we're going to have to close it off here. I really appreciate everyone for a fantastic set of presentations and panel discussion. Look forward to working with all of you. We certainly would look forward to providing some of these tools that you touched on in your presentations at the coalition website. We're happy to play a part in helping get your information published. We just really want to make sure we get this how-to for reflex testing out and disseminate broadly to promote good